Chronic inflammatory demyelinating polyradiculoneuropathy. CADP is an acquired immune-mediated disorder of the peripheral nervous system characterized by chronic progressive relapsing, stepwise weakness, and sensory dysfunction due to demyelination of the peripheral nerve and the nerve roots. It is considered chronic counterpart of Guillain-Barré syndrome. CADP is an immune-mediated demyelinating neuropathy involving the peripheral nerve and the nerve roots, causing symmetrical proximal distal weakness, sensory impairment, reduced or absent reflex, and disease progression more than 8 weeks. The 8 weeks duration differentiates CADP from AADP, the most common form of GBS. Epidemiology. Prevalence 1 to 9 people per 1 lakh population. Annual incidence 0.1 to 1.6 per 1 lakh population. Can occur at any age and peak incidence is about 40 to 60 years. Slight male predominance is present. Etiopathogenesis. CADP is an autoimmune disease involving both cellular and humoral immunity. Pathological features are segmental demyelination, remyelination, endoneurial inflammation, macrophage-mediated myelin stripping, onion bulb formation due to repeated demyelination and remyelination. The immunological mechanism involved is T-cell mediated immune injury, macrophage activation, complement-mediated damage, autoantibodies against nodal and paranodal protein in some patients. Antibodies may include neurofacin 155, neurofacin 186, contactin 1, and Caspar 1. These patients often behave differently from classical CADP and may respond poorly to IVIG therapy. These forms where autoantibodies are against nodal and paranodal proteins, such as neurofacin 155, neurofacin 186, contactin 1, and Caspar 1. These patients often behave differently from classical CADP and may respond poorly to IVIG therapy. Coming to clinical features, typical CADP, the classical presentation includes motor symptoms such as symmetrical weakness, both proximal and distal muscle affected, lower limbs affected before the upper limbs, difficulty in climbing stairs, difficulty in rising from sitting position, difficulty in combing the hair, and foot drop. Sensory symptoms include distal paresthesias, numbness, tingling sensation, impaired vibration and joint position sense, and sensory ataxia. Reflexes, there can be generalized hyporeflexia or areflexia. Cranial involvement can occur in minority of patients as facial weakness, ophthalmoplegia, bulbar weakness. Autonomic dysfunction is usually mild and uncommon. Clinical course, it can have 3 patterns which are recognized, that is progressive course, relapsing remitting course, stepwise progression course. Diagnostic criteria. The diagnosis is based on the clinical criteria 1, which includes progressive or relapsing motor sensory dysfunction, symmetrical proximal and distal weakness, hyporeflexia or areflexia, and duration of the illness more than 8 weeks. The electrodiagnostic criteria is nerve conduction study is the cornerstone for this diagnosis. The typical findings are markedly slowed conduction velocity, prolonged distal motor latency, prolonged F-wave latencies, conduction block, temporal dispersion, reduced CMAP amplitude in severe diseases. Evidence of demyelination should be present in at least 2 motor nerves according to diagnostic criteria. Cerebrospinal fluid findings, typical CSF findings, elevated protein, normal or mildly elevated cell count. This is known as albuminocytological dissociation. The typical values are proteins 50 to 200 mg per deciliter or higher, cells usually fewer than 10 cells per millimeter cube. The cell count more than 50 cells per millimeter cube should suggest an alternative diagnosis. MRI findings, MRI may demonstrate thickening of the spinal nerve roots, enhancement of the nerve roots, enlargement of the brachial and lumbosacral plexus. Nerve ultrasound may show enlargement of the peripheral nerves, enlargement of the nerve roots, multifocal nerve enlargements. Nerve biopsy, which is not routinely required, the findings of nerve biopsy usually include segmental demyelination, remyelination, onion bulb formation, endoneurial inflammatory infiltrates. The common biopsy site is sural nerve. Coming to variants of CADP. Variants of CADP, typical CADP, symmetrical sensory motor neuropathy with proximal and distal weakness. Second type, Distal acquired demyelinating sensory neuropathy, also called DADS, which is predominantly distal involvement, frequently associated with IgM paraproteinemia. Multifocal acquired demyelinating sensory and motor neuropathy, MADSAM, or Lewis-Sumner syndrome. Here we have asymmetrical weakness, multifocal involvement, and it resembles mononeuritis multiplex. Pure motor CIDP. Motor involvement only, sensory examination is normal. Pure sensory CIDP, sensory symptoms predominant, sensory ataxia may be prominent. Focal CIDP, it is restricted to one limb or one plexus. Differential diagnosis. Hereditary neuropathies like Charcot-Marie-Tooth disease, hereditary neuropathy with liability to pressure palsies, immune neuropathy such as multifocal motor neuropathy, paraproteinemic neuropathy, POEM syndrome, metabolic neuropathies like diabetic neuropathy, uremic neuropathy, ischemic infectious neuropathies like HIV neuropathy, Lyme's disease, vasculitic neuropathy like mononeuritis multiplex, systemic vasculitis. Others are amyloidosis, neurolymphomatosis, and chronic GB syndrome. Coming to treatment. Treatment, first line therapy is corticosteroid. For example, prednisone 1 milligram per kg per day or pulsed dexamethasone regimens. Advantages of this therapy is effective in many patients, it is inexpensive. Intravenous immunoglobulin therapy 2 gram per kg given over 2 to 5 days. Maintenance we can give 0.4 to 1 gram per kg every 3 to 4 weeks according to the response. This is often preferred modality because of rapid improvement. Coming to plasma exchange, third type of therapy, the typical regimen followed is 5 exchanges of plasma over 2 weeks. It's useful for severe disease, treatment resistant disease, and rapid deterioration disease. The second line therapy used in refractory diseases are azathioprine, mycophenolate mofetil, methotrexate, cyclophosphamide, cyclosporine, rituximab, tacrolimus. Rituximab in particular is used for IgG4 nodal and paranodal antibody positive neuropathies. Coming to prognosis, approximately 80 to 90% of patients will respond to treatment. Some achieve long-term remission, others require prolonged maintenance therapy. Untreated disease may result in significant disability due to axonal loss. Poor prognostic factors include severe axonal degeneration on nerve conduction study, delayed treatment, long disease duration before the diagnosis, associated nodal and paranodal antibodies. The important differences between CIDP and AADP. CIDP duration to nadir is more than 8 weeks. Course is chronic relapsing. Relapses are common. Steroid response is good. Maintenance therapy is often required. AIDP duration to nadir is less than 4 weeks. Course is monophasic. Relapses are rare. Steroid response is ineffective or may even be harmful. Maintenance therapy is usually not required. So, diagnostic triad of typical CIDP is progressive symmetrical proximal distal weakness for more than 8 weeks, generalized hyporeflexia or areflexia, electrodiagnostic evidence of demyelinating neuropathy. Let us understand nodopathy and paranodopathy. The anatomy of the myelinated peripheral nerve. A myelinated nerve fiber has a specialized regions, that is myelin sheath followed by paranode followed by node followed by paranode and again followed by myelin sheath. It is more accurately you can say it as internode, which is myelin sheath, then paranode, then node of Ranvier, then paranode again, and then again internode. The internode is the region covered by the compact myelin. It is responsible for electrical insulation. It's produced by the Schwann cells. The node of Ranvier is the small gap between the two myelin segments, which is rich in voltage gated sodium channels. It is the site where action potentials are regenerated. Coming to paranode, this is the region immediately adjacent to the node. It contains specialized axoglial junction. It functions like adhesive seal attaching to the Schwann cells loop to the axons. Juxtaparanode. This is located just beyond the paranode. it is rich in potassium channels. The important proteins in this region, at the node of Ranvier, we have neurophasin 186, sodium channels that is NAV 1.6 and gliomedin. At the paranode, we have neurophasin 155, contactin 1 and Caspar 1. At the juxtaparanode, we have potassium channels like Kv 1.1, Kv 1.2. What are paranodal proteins? What do these paranodal proteins do? These proteins maintain tight attachment between Schwann cell myelin and axon. So Schwann cell loop is attached to axonal membrane via NF155. NF155 is present on the Schwann cell side. Contactin 1 and Caspar 1 are located on the axonal side. Together they form paranodal junction. So what happens in the classical CADP is, in classical CIDP, macrophages will invade the peripheral nerves, myelin is stripped away and segmental demyelination occurs. Conduction slowing and conduction block will develop. Thus, classical CIDP is primarily immune-mediated demyelination. These patients usually respond well to the corticosteroids, IVIG and plasma exchange. What happens in paranodopathy antibody disease? Some patients previously labeled as CADP actually have antibodies against paranodal proteins such as anti-neurophasin 155, anti-contactin 1 and anti-Caspar 1. So these antibodies do not destroy the myelin directly. Instead, they will disrupt the attachment between myelin and the axon. So this causes loss of saltatory conduction, conduction failure and severe neuropathy. This mechanism is called paranodopathy or nodoparanodopathy. Why are these patients different from typical CADP patients? See, classical CADP, the target is myelin, the mechanism is demyelination, macrophage mediated demyelination is present there, onion bulb formation is common, conduction block is common, IVIG response is good, steroid response is usually good, rituximab response is variable. Whereas when it comes to paranodal antibody neuropathy, the target is node or the paranodal antigen, mechanism is axoglial junction disruption, macrophage mediated demyelination is absent, onion bulb formation is rare, conduction block is common, IVIG response is very poor, steroid response is variable, rituximab response is often very good. The clinical clues suggesting of paranodal antibody disease is the clinical clues suggesting paranodal antibody disease. So you should consider nodal and paranodal antibodies if a patient has very severe neuropathy, tremors, sensory ataxia, markedly elevated CSF protein more than 200 to 300 mg per deciliter, distal predominant weakness, poor response to IVIG, early axonal loss, rapid course despite the treatment. Anti-NF55 155 patients classically are having a feature like younger age of onset, prominent postural tremors, sensory ataxia and distal weakness. So what about the anti-ganglioside antibodies? The anti-ganglioside antibodies, the gangliosides are completely different targets. Gangliosides are the glycolipids present on the neuronal membranes. The example for these gangliosides are GM1, GD1A, GD1B, GQ1B, GT1A. These are not paranodal structural proteins. The disease associated with anti-ganglioside antibodies are anti-GM1, multifocal motor neuropathy Aman variant, anti-GD1A Aman variant, anti-GQ1B Miller-Fisher syndrome, anti-GT1A pharyngeal cervical brachial variant of GBS, anti-GT1A pharyngeal cervical brachial variant of GBS, anti-GD1B sensory ataxic neuropathy. These antibodies are most commonly associated with Guillain-Barré syndrome variants, multifocal motor neuropathies, and acute axonal neuropathies. The relationship between antiganglioside and the paranodal antibodies. When it comes to antiganglioside antibodies, the target is a membrane glycolipid. The common disease is GBS and MMN. The typical disease course is acute or subacute. The main pathology is axonal dysfunction. The IVIG response is usually good. Rituximab response has a limited role. When it comes to paranodal antibodies, the target is a cell adhesion protein. The common disease is CADP variants. Typical disease course is chronic. Main pathology is nodal paranodal disruption. IVIG response is often very poor. Rituximab response is often very effective. So current classical classification concept is the modern peripheral nerve immunology divides immune neuropathy into one demyelinating neuropathy, which includes classical CADP, DADS, and MADSAM. Next, we have nodopathies and paranodopathies like anti-NF155 neuropathy, anti-contactin 1 neuropathy, anti-Caspar 1 neuropathy. Thirdly, we have ganglioside antibody neuropathies like Aman variant, Miller-Fisher syndrome, multifocal motor neuropathy. So, the confusion here is CIDP, nodopathy, paranodopathy, and anti-ganglioside antibody neuropathies is solved. Coming to diagnostic criteria for classical CIDP, the diagnostic criteria for classical CADP is 2021 EAN or PNS criteria. Step 1, the clinical criteria. Patient should have typical CADP, which is progressive or relapsing symptoms for more than 8 weeks, symmetrical proximal and distal weakness, sensory involvement, reduced or absent reflexes. Example, difficulty in climbing stairs, difficulty in rising from squatting, hand weakness, distal numbness and areflexia. If these features are present, then you need to proceed for the nerve conduction study. The step 2, electrodiagnostic evidence of demyelination. That is, it is the hallmark of CADP. The hallmark of CADP is demyelination on the nerve conduction study. The typical findings include motor conduction velocity slowing, prolonged distal motor latency, prolonged F wave latency, conduction block, and temporal dispersion. For the definitive CIDP, demyelinating abnormalities should be present at least in 2 of the motor nerves. Coming to step 3, which is supportive features. These are not mandatory but support the diagnosis like CSF protein elevation, root enhancement on MRI, nerve enlargement on ultrasound, objective response to immunotherapy, nerve biopsy showing demyelination. Therefore, CADP diagnosis requires clinical syndrome plus demyelinating NCS without any other better explanation. When it comes to nodopathy or paranodopathy, these patients are often exactly like CADP when it comes to chronic progressive neuropathy, weakness, areflexia, and elevated CSF protein. Therefore, many will initially satisfy the CADP criteria. However, the underlying pathology is different. 1. The diagnostic criteria for autoimmune nodopathy. The diagnosis of autoimmune nodopathy requires the clinical neuropathy, clinical neuropathy in the form of chronic progressive neuropathy, sensory ataxia, tremors, distal weakness, and areflexia. Positive antibody testing like anti-NF155, anti-contactin 1, anti-Caspar 1, anti-NF140 or 186. This is the most important criteria for it. Compatible phenotypes I will explain you. For example, when it comes to anti-NF155, the compatible phenotype is younger age, marked tremors, sensory ataxia, and very high CSF protein. When it comes to contactin 1, the aggressive onset, severe weakness, and early axonal loss. So let us understand why were these patients previously were called as CADP patient, because they fulfilled the traditional CADP criteria in the form of chronic course, areflexia, elevated CSF protein, and demyelination on NCS. So only after when we diagnosed antibody testing were developed, the antibodies were diagnosed and diagnosis became clear. So the current classification is classical CADP, which requires clinical syndrome, demyelinating NCS, and no better explanation. The second type is autoimmune nodopathy, where we have chronic neuropathy, positive nodal and paranodal antibodies, and compatible phenotype. So let us discuss the approach. So the practical approach is when a patient presents with chronic neuropathy which will last more than 8 weeks duration, so you should check if NCS shows any demyelination. If NCS doesn't show any demyelination, then you should consider hereditary neuropathy, vasculitic neuropathy, amyloid neuropathy, axonal neuropathy. If NCS shows demyelination and patient has chronic neuropathy, then you should diagnose CIDP clinically. When it comes after diagnosing CIDP clinically, you should look for red flag signs. That is, severe sensory ataxia, prominent tremors, very high CSF proteins, distal predominant weakness, poor IVIG response, early axonal loss. If these red flags are present, then you should test them for nodal and paranodal antibodies like NF155, contactin 1, Casper 1, NF186. If these are positive, then you should classify them as autoimmune nodopathy. Thanks for listening. Please subscribe to the channel.